Okay, so welcome to episode 2 of the Harley Street Health podcast. Today we are joined by Dr. Sriram Narayanan, the Senior Consultant Vascular and Endovascular Surgeon at the Harley Street Heart and Vascular Center, based at Gleneagles Hospital. He's the General Secretary of the Asian Venous Forum and faculty for the Venous World International Foundation for Pelvic Congestion and Deep Venous Surgery. And today we're going to talk about something called pelvic congestion syndrome, which is something I don't know a lot about. So I am pretty keen to find out a bit more from Ram. So what is pelvic congestion syndrome, Ram?
Well, pelvic congestion syndrome is a set of symptoms that are so common that most girls and women are told to live with it and to get on with it.
Wow.
Essentially, it is chronic pelvic pain, especially pain just on the day before the period or on the first day and the second day of the period. You all are aware of young girls and young women who are doubled up. They carry bits of Brufen and NSAIDs in their handbags. They have a sort of relationship with their hot water bottles at this time. Also, it's associated with heavy periods. Usually clots or periods can go on for 5, 6, 7, 8 days. I've had patients who had periods for 21, 22 days in a month. So it's a combination of 3 basic symptoms. It's positional pelvic pain that gets worse just before or around the period. It's associated with heavy bleeding, and it's associated with pain during sexual intercourse or dyspareunia. Now, you would have thought these 3 symptoms are fairly common, and women are just told it's part of being a lady. Mothers tell their daughters, when you have your babies, it'll all get better. Sadly, it often doesn't. And women live their life through it and suffer from it. And about 15% of women in the world actually suffer from pelvic congestion syndrome.
Wow, 15%. And how many of them actually get? How many of them actually get diagnosed? Or do they just
well, it's 15%, but the diagnosis of pelvic congestion has been really difficult to make for many years. And the reason for that is that there's such a big overlap with many other gynecological conditions, which actually form the other 85%, which is endometriosis and fibroids and ovarian cysts. Because of that overlap in symptoms, they don't get diagnosed. The other reason why they don't get diagnosed is because we have only just understood over the last 7 to 10 years what is the basic pathology, the reason why pelvic congestion syndrome occurs. We now understand that it's not a gynecological condition, but it's actually a vascular condition. So there's been a shortage of knowledge on it.
So it's basically like, is it kind of like varicose veins actually in the pelvis?
Yes, it is. Essentially, what happens is that the blood pools in the pelvis, and that pooling occurs because of compression from 2 sides. You see, the strange thing is we were never designed to stand. We were designed to live our life on all 4s. But when we decided to stand, we created some problems. We created this blood column from the heart down to our legs. And the blood now has to return from our organs against gravity. So that was problem 1. The second problem we created was 2 compressions on the veins as they come back, bring the blood back toward the heart. One compression is the vein in the pelvis as it's leading out of the leg. It takes most of the blood out of the leg, called the iliac vein, and there's an artery sitting on top of it. When you're on all 4s, everything falls forward, but when you stand up, you stretch the vein and the artery against the spine, so the vein gets compressed by the artery against the spine. So there's a sort of back building up of pressure that the blood has to drain against. The other place where we created a compression is where the vein from the kidney drains out, and your ovarian vein on the left side is attached to this vein or drains into this vein. So a second compression was created there. So the net effect is that you've got a sort of back damming of blood either in the legs and the pelvis or around the ovaries. And the blood then pools inside the pelvis. And obviously, during the time of the period, when there's an overall increase in blood flow to the uterus in that area, it all gets worse. During intercourse, when there's an increase of blood flow to the pelvis, it all gets worse. So yes, it is essentially varicose veins in the pelvis.
So if a woman has these symptoms are all very, very common, and obviously these women present to a gynecologist first of all. How would they know that this is pelvic congestion syndrome and not something else? I mean, what are the key factors that point towards pelvic congestion syndrome?
There are some key symptoms in the pain. Firstly, the pain is position. So standing or sitting for a long time tends to make the pain worse. So in the beginning of the day, it might not be that bad, although there's some degree of pain, depending on how bad the compression and the pelvic congestion is. But as the day progresses, there's this feeling of heaviness and pain and stretch somewhere deep inside the pelvis. So it is positional in nature. And this sometimes is the problem because most gynae examinations are done with the patient lying down, with their legs on a stirrup or whatever, and the blood then has already started draining, so you don't quite get the same symptoms. The other problem, of course, in making the diagnosis is that the pain that occurs during intercourse is very characteristic. While conditions like endometriosis or local conditions in the uterus or in the vaginal region can cause pain during intercourse, with pelvic congestion, the pain is typically post-coital. It occurs after the intercourse is over, and it can be agony and ache that can last for even up to a day or 2 days after. And the problem with this is this obviously begins to affect relationships. As you can understand, if the mental memory is that every time you're intimate with your partner, you're going to be left with agony for the next day or two, the sort of intimacy, it does wane over time. The third issue, of course, is the bleeding, but the heavy bleeding and the clots, of course, is an overlap that occurs with many other gynecological conditions.
So what type of people get this condition? Is there risk factors? Is there things that people can do to prevent it?
Yeah, most people, of course, are in the childbearing age group. So it begins as ovulation begins around 14, 15, 16, with as puberty happens. And then it usually disappears in most people as they reach menopause. But it gets worse with every pregnancy. And there are reasons for that. We know that having a lot of estrogen, or what's called a hyperestrogenic state, some women are naturally more feminine, if you want to put it that way, and have more estrogen. But estrogen also causes the veins to collect blood. It increases the diameter of the veins. In addition to that, with every pregnancy, there is another hormone called relaxin that is secreted that makes the veins get even more sort of capacious and be able to hold more blood. And of course, as the baby grows and the uterus expands, the blood flow in the pelvis can go up anything between 18 and 20 times. So with every pregnancy, you're sort of left with this distended, dilated system of veins inside, which have far more capacity to hold blood. So to this, if you add the compressions, then with every subsequent pregnancy, it can get worse. The other thing, of course, is body weight. I know that a lot has been said about being overweight and that not being good for you. And sadly, girls are trying to achieve waif-like figures with body mass indices of what we call Singapore size 0, somewhere between 18 and 19. The thing is, the thinner they are, especially if they're extremely thin, then the compression on the ovarian vein is much more. And so very thin women can have more symptoms of pelvic congestion.
Why is the congestion more if they're thin? Is it to do with less
okay, so it's strange. So you have the kidney vein coming out from the left side, and then you have the big artery that goes down called the aorta, which is just behind it. And this vein is crossing over in front from the left to the right. And then from that aorta is another artery that comes out that goes to the gut called the superior mesenteric artery. Now, the vein is actually trapped in between the two, something like that. And so if they have a bit of fat, then these two arteries are separated by a pad of fat. And so the amount of compression they cause on the renal vein is less.
Right.
So very thin women tend to get ovarian symptoms much more. On the other hand, if women put on a lot of weight, then there's a fat pad called the omentum, which is like an apron of fat that descends into the pelvis, and that causes compression in the veins of the pelvis. So really the ideal body shape is not too thin and not too overweight and just right, which is probably the best way to try and avoid the compressions for pelvic congestion.
So, okay, so how is it diagnosed? What do you do to actually diagnose this syndrome?
Well, the first thing to do is to understand that the 85% I referred to, the other gynecological conditions do need to be ruled out. Mm-hmm. It is rare for the patients to come to us first, but if they do, they should be sent to gynecology to rule out whether they have fibroids and cysts in the ovary and endometriosis. To diagnose these conditions, the gynecologist would usually have done what's called a pelvic ultrasound or a transvaginal ultrasound, which is an internal ultrasound scan. While it feels the same when we do a diagnosis with what's called a pelvic duplex, the procedure is actually different. So we go through stages in our diagnosis. The first stage is to make sure they don't have any other condition that is gynecological. Right. The second step is that we run through what's called a pelvic congestion syndrome screening questionnaire. This has 6 questions, and the questions are fairly straightforward. Do you have pain when you stand in the pelvis? Have you had pain for more than 6 months? Is it associated with sexual intercourse? Do you have any bleeding in the urine? Do you have any recurrent infections in the urine? So it's a fairly straightforward set of 6 questions. Women who have pelvic pain for 6 months or more and score more than 3 on this questionnaire out of 6 are very likely to have dilated veins in their pelvis. So once we've done that screening, we then move on to the next step, which is an internal ultrasound. But our ultrasound is a duplex, which is to say we don't just look at the solid organ, we also look at the direction and the volume of blood flow in the veins. The gynecological ultrasound does look at the solid tissues, at the uterus and the ovary, and we do that too. But in addition to that, we also look at the direction of blood flow and what is the volume of blood flow that is pooling in the pelvis, and various other little parameters which are vascular. So when that sets us up to say it is pelvic congestion syndrome, then we discuss with them what needs to be done next.
Yeah, I guess that kind of leads on nicely. What are the treatments for this? Are they all surgical? Is there medication they can take? Or
the treatments are really dependent for us on 3 things. What is the age of the patient when they have presented to us? How severe are the symptoms in terms of affecting quality of life? There's a whole range, as you can imagine, from some degree of discomfort to patients who for 2 to 3 days in a month will routinely take time off work, have medical certificates for it. In fact, their colleagues know, okay, it's the time of the month, she's not going to come to work. We've had patients whose bleeding is so heavy that they have embarrassed themselves, soiled their clothes, have had to leave work. We have patients who've had repeated failed relationships because of the pain from the sexual intercourse. And so it depends on the severity of symptoms. It depends on the age at which they present. And why is the age important? If they're extremely young and they haven't had pregnancies or are planning to have pregnancies, our approach is a bit different. Of course, if they're not married and one assumes, and it's probably the wrong thing to do, is assume that they would have had no intercourse. But we do not do a transvaginal ultrasound on someone who's not sexually active. For obvious reasons. It can be assessed without doing an internal examination straight through the pelvis, but it's not perfect, but it can be assessed without a transvaginal ultrasound as well. And then the third factor that comes into play for the treatment is, of course, where is the compression? Is the compression primarily in the renal vein and the ovarian vein system, or is it in the veins that are leading out of the leg? And the treatment is different depending on where it is.
But what is the treatment then? So if it is at the renal side of things, what would you do?
Okay, so let me go over the renal side first. So essentially, when there's compression of the renal vein and the ovarian vein, the aim is to try and stop that pressure from being transmitted from the veins from the renal vein down into the pelvis. So what we do is we plug the ovarian vein, we block it, so that there is no back pressure transmission. There are various no, there are various ways to block it, and it can cause problems in some scenarios.
Right.
Okay. So you can either block it by putting something mechanical called a coil or a plug, and it mechanically stops the pressure from being transmitted. But of course, if it's a 25, 30-year-old who may be wanting to have more children, then that ovarian vein will increase in size if they get pregnant. And so the size of the coil or the plug that we have put in may not be enough. And that plug can then get dislodged. So if they are planning more children, we don't put any implants in. Instead, we use what's called a sclerosant, which is a drug that scars the vein. And we take that down and control that drug with a balloon so that the drug doesn't fly off everywhere else. And we basically isolate that system. It's a minimally invasive X-ray guided procedure. And then we inject the drug to cause scarring only in the varices. The problem with this, of course, is if they do get pregnant in the future and it starts dilating again, there is about an 8 to 10% chance of recurrence after pregnancies. But we do not want to risk putting implants in these patients. On the other hand, if the compression is now coming from the iliac vein, then the principle is to take the blockage and open it up by using something called a stent. So essentially, we put a tube within a tube. These are bare metal stents. They are made of a material called nitinol, which is a nickel titanium alloy. And it keeps that artery from compressing the vein and increasing the pressure. Of course, in very severe cases, you might have to do both. You may have to deal both with the ovarian side as well as with the iliac vein side leading out of the leg.
And does that stent, does that stay in long term? Do you remove it at a later date, or is it always there?
No. This is the consideration that is important. So the patient's lifestyle is important. These stents stay in forever. They are there for life. It's an implant, and the implant is not easy to remove. Of course, in extreme cases, it has been removed, but this is rare. It's not a small procedure to remove an implant. So we think a lot about putting an implant in. If the compression is not too much, you can actually just dilate the vein with a balloon and let the patients know that the symptoms may come back over time, but at least nothing has been left behind. Sometimes we try and buy time when they're in their late 40s towards actually them getting menopausal fairly soon, when the pelvic congestion symptoms can come down. So it depends on the age of the patient and where the compression is. The other thing to remember with these stents is that they were not designed to do yoga. So if people are the sorts who are going to try and reach their nose with their toes and have extreme extensions and flexions, there is a small risk that the stent may fracture. And if it does, then they can form clots. So the assessment is really made on the age of the patient, on whether they are planning more pregnancies, what stage of their sort of menstrual life they are, how severe are the symptoms. We've had 25-year-olds with such severe pain that they've approached gynecologists saying, do a hysterectomy, take my uterus out. I don't want any babies. I just can't take the pain.
Wow, okay.
Sadly, of course, a hysterectomy will get rid of the bleeding problem for obvious reasons, but it doesn't get rid of the pain. The congestion stays because the varicose veins in the pelvis and around what was the uterus has not gone away. So the pain.
Did you find, this PCS, are most gynecologists aware of it? I mean, is there awareness or?
Gynecologists are becoming aware of it. in the sense that they understand and have known for a long time that there is this condition of chronic pelvic pain for which they might not have had solutions in the past. In fact, PCS is probably one of the few scenarios where a private gynecologist will refer to another private gynecologist, even if it is only to get the patient off their hands because they don't have any solutions.
Right.
It is frustrating because the gynecologists have gone through the process. They have done the assessment. They've had laparoscopies and hysteroscopies and CT scans and ultrasounds over many years. They have attempted all the medical treatments for it with Mirena coils, with hormone implants, with painkillers. So this process has usually been followed for a few years, and they're not winning. The problem is that while they have known about pelvic congestion, all of us, whether it's vascular surgeons or gynecologists, haven't really known about these compressions. And it was only in 2007 and then 2011 that the first description of these compressions came about. And so we have only just understood over about 10 or 15 years what is the cause of these. In addition to that, the treatments that we are now able to offer, which I mentioned, stents and coils, they were not available 15 years ago. And so it's a combination of the fact that our knowledge about the condition and what causes it has improved and changed dramatically, actually, over the last 10 years. And the equipment we have and the treatments we have available for it has also changed. So and probably what's changed completely is the arrival of something called intravascular ultrasound, that we can look at these veins with ultrasound during a procedure from the inside. We can actually measure the size of these veins, see the way the blood is flowing. We can see the disease in the wall of the vein, something we were not able to do before. So a lot of equipment has changed, and that's allowed us to treat them better.
We'll probably have to wrap things up pretty soon, but in terms of these procedures and how successful are they? I mean, does everyone get abatement of symptoms, complete abatement, or just a little bit? And what happens afterwards?
For those who failed medical treatment, and if you've actually pinned down where it is coming from, the 1-year symptom-free status is in excess of 85%. And in even those who have about 15% of people who have some symptoms remaining, there's a significant decrease in symptoms. The people who tend to be in that 15% tend to be the women who we haven't put coils in because they are planning pregnancies, but that is a trade-off that we have to make. Yeah. It is okay to stent people, but we so far we don't have enough data to know what to do with those who have coils. So there's a huge improvement in quality of life, and the PCS scores often come down from 5 or 6 to 0 at the end of the procedure. But it is important for them to know that if they expect to wake up the next morning after the procedure and be perfectly normal, that is not true. It takes about 2 or 3 cycles before all the symptoms settle, but usually by the 3rd cycle, they're a lot better.
Okay. Now, just to kind of wrap things up, Ram, what would you say to women that are experiencing these symptoms just now? What would you say to them? What should they do? Should they go straight to you, or should they go to the gynecologist? And what's your advice?
Either way, it's their choice. If they go straight to the gynecologist and they have been with their gynecologist for some time and the symptoms aren't going away, then they either need to ask the gynecologist to refer to us, or they can come to us for an opinion. On the other hand, if they come first to us with pelvic congestion syndrome, then after a PCS score and an ultrasound, we will not intervene straight away. We will refer them to a gynecologist first, because it would be silly in someone with a commoner condition like a fibroid or an ovarian cyst for us to start putting implants in them. That needs to be ruled out first, and only after a full gynecological rule out has happened would we consider intervention. There's a lot of talking through to be done with the patient, and we don't offer procedures straight away. We do walk them through what to expect, and they have to make the call on whether it's bad enough for them to require treatment.
Okay. And is there anything else you'd like to add that you've not said, you think is important we should talk about before we?
Yeah, the key thing for women to understand is that the legend or the myth that women just have to live their life with a certain degree of suffering is no longer true. To have pelvic pain across a period, to have painful intercourse that you don't want to tell your partner about, that to have heavy bleeding. And these are things girls talk between themselves and with their girlfriends, but they never talk to their partner about. And so the partners don't quite understand it. So please don't think that this is a woman's lot to suffer this. It is possible to alleviate these symptoms now and for you to have a much better quality of life. So don't have to suffer for the rest of your life with it. At least get a consult. And then if it's severe enough and requires treatment, then you can make the choice on that.
Okay, great. Well, that was really excellent. Thank you very much, Ram, for that really informative.
Thanks so much, Michael, for having that.
And hopefully the audience has enjoyed the podcast today, and we'll be producing one every 1 or 2 weeks about different health topics. Thanks again.
Thanks a lot, Mike.